As acting chair, I'd like to call this meeting to order and ask the secretary to call the roll.
And we have two substitute members serving today on site. We have Director Harrington and Director Story serving as substitute members. So the roll call, Director Garza.
Present.
Director Harrington.
Present.
Director Sorrell.
Present.
Director Story.
Present.
Director Webster Cross.
Present.
And Chair Bott.
Present.
You have a quorum.
Thank you. The next regular meeting of the Quality and Patient Safety Committee is scheduled for Thursday, October 12th at 10:30 a.m. We do need a motion to allow directors who are participating remotely to serve as voting members. Can I get a motion to that effect?
So moved.
Is there a second?
Second.
Motion is moved. Does it need a vote?
Yes, voice is fine.
Voice. The motion has been approved and seconded. All those directors in favor say aye.
Aye.
Any opposed? Hearing none, the motion carries. This time, I guess I can turn it over to Chair Bott. At this time, I'd like to turn the meeting over to Chair Bott.
Thank you, Director Harrington. Appreciate you stepping in. I'd like to move to our informational items, and let me start with good morning to everyone. Is there anyone registered to provide in-person or virtual oral testimony, Debbie, to be included in the record?
No, we did not receive any.
Okay, great, thank you. We'll now move to our report on quality and patient safety matters. But before we do that, I also, related to this, wanted to update the board that we had requested the Joint Commission Health Equity Certification Standards in a previous meeting. Those are now finalized by the Joint Commission, and those are have been sent to the board. So thank you, Debbie, for that follow-up, team. And if there are any questions, we can follow it up later. But I will now hand it to Dr. Makaitis to review the HRO dashboard and update on strategic initiatives.
All right. Thank you, Chair Bott.
Thank you.
Good morning, directors.
Good morning.
Dr. Eric Makaitis, Chief Quality Officer, Cook County Health. So as always, we'll start with patient experience on the dashboard. You can see we're slight uptick in likelihood to recommend for Stroger. Again, a low volume of returns in general in terms of the raw volume that we've seen lately. We did do a deep dive in terms of the number that we're seeing, and we're at about 12%, which is actually on par with most organizations. We do have several tactics in place that we're trying to implement and that will help kind of cast a wider net, but also encourage better return. If we go to the next slide, I wanted to actually—
Are you attributed to a lack of return?
So it's a mix of things. There's a small volume that's undeliverable. We do have some tactics in place there where we have nursing following up after patient access registers the patient to confirm that that's actually accurate. Again, not a whole lot of juice worth the squeeze there. We only had about 80 returned as undeliverable in the month of July. We are working with Precani as well to change that net that we're casting. I know Andrea helps kind of illuminate the various algorithms that drive who gets a survey. We've been discussing with Prescani how we primarily focus on inpatients instead of like if they get imaging a week before and then they get admitted, that they may end up not getting an inpatient survey. They'll fall out based on the algorithm. So it is a discussion that we're having with them. And then there's also a really nice tactic around better understanding with patients who submit a survey and give us their contact information, allows us to then reach out to them. Our nursing leadership team is actually going to be following up on the back end to call those patients and better understand what prompted them to give those surveys back to us. And we're going to look for some common trends and really try to see, what could we be doing differently as we engage in with patients during nurse leader rounding to try to prompt them, in a compliant way, of course, to return their surveys when they do receive them. So a couple of strategies are in place to try to increase.
Yeah, and it looks like between March and June, we were fairly stable, and then there was a big drop, and we're gone up a little bit. Is there anything we're doing during March and June that's different than what we're doing now?
So nothing driving specifically to likelihood to recommend. We did have, I'll show on the nursing slide, we did have a bit of a drop there too. We had Press Ganey in actually in August to really sit down with our leadership teams to talk through tactics and deselection and really focusing in on one or two things and going a mile deep. You know, there's often kind of a drive to do a lot all at once, right? And it kind of leads to, you know, maybe a little bit of, you know, loss of focus. So we're, you know, they came in, they really pushed on that to say, okay, let's work together, let's focus in where the juice is really worth the squeeze, as I said, and then kind of strategize how we operationalize there. I do want to show though, there's the next slide, is we zoomed out a little bit and showed 6 quarters of data, and you can see there's a bit of a dip over the course of 22, and we hit our low point actually in Q4 of 22. Interestingly, Q2 of 23 is actually our best in that year and a half. So we did have a really nice recovery into early 23. So just kind of a slightly different perspective to kind of show that, you know, yeah, there was a bit of a dip in the last few months, but there has been a really nice, you know, improvement when you kind of zoom out.
Thank you.
Just a quick question, Dr. McCann. What does Press Ganey say about other institutions of like size and complexity?
In terms of
Their effort.
their return, well, so they've been, a lot of what they offered when they came in August is kind of, you know, best practice. They've also, in terms of return rate, we've looked at other organizations and we're right in the mix. We're right in the mix in terms of what we're getting back. It's you know, kind of the high single, low double digit range, so like 8 to 15%-ish. And you know, in July, we think we were mid 12%, 12.5-ish% for returns for survey sent.
What would they expect as the norm? Is it 30%, 25 to 30?
No. So, I mean, we're shooting for as high as we can get, but, you know, as I said, the other institutions, we're seeing kind of the norm being, you know, 8 to 15-ish% as a normal return. We're sitting at about 12 in July. So we're right in the mix. All right. So if we go to the next slide, this is our nursing communication performance. Again, a little bit of a dip. We engaged, as I said, Press Ganey in August. So kind of a redoubling of efforts in terms of focusing in on specific tactics at the bedside, nurse leader rounding and CI care being the main ones. Next slide. This is our hospital environment, still at gold, but we did see a dip. Again, you know, not super concerned until we really see it kind of consistently dropping. Again, still at gold. Next slide. So this is the first time we're going to be looking at Providence. As I mentioned last time, we've launched a few of our committees at this point and are offering this information as a baseline. We're going to be doing patient experience, throughput, and sepsis specifically at Providence. So those 3 are now launched, or I should say, one has started their meetings. The next 2 are starting in the next week or 2. So patient experience, we met actually yesterday to start planning the kickoff. They have their A3. So more to come on this, but we just wanted to kind of set the baseline for all of you to show where we're starting from. Next slide. Oh, and again, just a call out for Provident. We're still on Provident here for communication, but our surveys here too, just to call out the volumes, we're in low double digits, and this is by quarter, right? So we're getting just a handful every month. We're shooting to try to get up to 30 surveys per quarter, which will be statistically significant. So that's our goal, to really try to, you know, make these numbers really meaningful. Our communication with nursing, you know, looks really great. Again, numbers are very low, but you know, we'll take it. They're at their stretch goal right now. Next slide. Communication with doctors, a bit of a downturn from Q2 to Q3, but you know, we have some tactics in place: physician shadowing, coaching on CI care and commit to sit, various interventions that really, you know, kind of help the docs engage with the patients. It's not really an issue here. They have fantastic. It's probably our best domain here at Stroger is our physician scores. So we'll be working with the docs at Providence.
The N is the number of people who return.
Those are return surveys. Yeah, and that's a quarterly number, right? So it's across 3 months. We're only getting, you know, 15 to 20.
You know what that is in terms of percentage of the numbers?
I don't. I can get that for you next time. Yeah. All right. We'll switch to clinical documentation. Again, CMI has been relatively flat. A lot of the work has been done over the summer in terms of intervention. We also have Dr. Batosho here to talk through kind of a deep dive on what he's our executive sponsor over clinical documentation. He'll be talking through some of our strategies that are on the horizon. Next slide. Clinical outcomes. Very excited to continue to share this incredible work. So our SEP1 bundle has now, I think this is a 2-month update. We only had the 273s last time, so we have 2 months now of 81%. And hot off the press this morning, I was going to try to keep it under my hat until next month, but we just learned that August is actually 92.8% for compliance. So continued improvement there. Very exciting. It puts us at, I think, 65% year to date for bundle compliance, which is, it's fantastic. Just for frame of reference for the CMS star rating, we were at, I think, low 20%, 22, 24% on that measurement period. So for calendar year 23 now, we're in the mid high 60s. So a very nice improvement. Should help.
Congratulations.
Yeah, great.
Thank you. It was a massive team effort. It's
Excellent.
very good job. So this is our C. diff volumes. Again, we're just counting all volumes. We're working to bring SIRs when they're available. That's kind of the publicly reported number. It's an infection ratio. However, we are on task for about a 50, or on track, I should say, for about a 50% reduction year over year. We were at 43 cases in 2022. We're right now at 16. 2 of those are still being validated. So it'll fall somewhere between 14 and 16 for the month of August. Assuming a linear trend, it puts us on track for 24 for the year, which should just come in better than our stretch goal. Next slide. Okay, we're going to shift to Provident again. This is, again, low numbers, just to call that out. So that's why you really see that kind of violent sawtooth pattern. But you know, already the 12-month rolling is in the high 40s. You know, we're working again through process improvement, much like we did here at Stroger, to help kind of drive some consistency in how we respond when we identify septic patients. Next slide. We're going to shift back to Stroger here. This is our left without being seen. Again, we're kind of just monitoring this at this point. This was a process change, just as a reminder, back in December, moved our ED physicians closer to the front door. So they minimized the wait between triage and being seen by a physician. And we see the results there in terms of left without being seen down into low single digits. This month, a very nice drop down to 2.5%, beating our stretch goal.
Yeah, I have a question.
Yes.
A lot of people that go to the emergency room don't really require emergency services. And so I'm assuming a lot of people left just got bored and left and didn't really have a major medical complaint.
Yes. So yes, the issue here was when, you know, originally when we were seeing kind of the double digit left without being seen, they would have their triage and everybody kind of waited until they were able to come in, unless it was, you know, they were horizontal and on a stretcher and had to be seen right now. The docs and medical staff leadership changed that process. So now there's a triage and a physician or an APP lays eyes on the patient almost immediately, allowing them to give them that guidance to say, this is kind of a primary care visit. You're probably going to wait, but we're going to make sure there's nothing dangerous going on. It then lets also them identify those truly, you know, they're here with chest pain or indigestion. I think Dr. Fegan wants to add something. But yes, it helps them kind of, you know, triage out who actually is an emergent visit.
Claudia Fegan, Chief Medical Officer for Cook County Health. In the emergency department, we have 3 areas. There's a green team, there's a red team, and there's a blue team. The green team is Dr. Quick, and those are patients who are seeing sore throat, cough, need a prescription, sprains, strains, small, broken long bones. When we staff Dr. Quick, so they're seen by a physician right away, as Dr. Makaitis alluded. Then we have the drop in left without being seen goes way below 10%, down into less than 5% at a point of time. And when we don't staff Dr. Quick, sometimes on the weekends when there are fewer physicians, then the left without being seen goes dramatically up. But I'm heartened by the fact, because I've talked to CMOs at several of the other larger institutions who are dealing with left without being seen rates in the 10 to 15 range. So I think there's opportunity there, and I think we know the solution. We just have to be consistent in that, and I have a meeting scheduled for, I think, this week still to address that.
All right. I think
Great.
we can go to the next
Thank
slide.
you.
Thanks, Debbie. All right, this is our median length of stay. We see a nice drop towards goal. Again, some process change underway. They did a CT mapping project that is going to drive some additional process change. And they are working with our frontline teams to better identify discharge times. That helps with data integrity. So our data teams are engaging our clinicians to help kind of more clearly define when patients are discharged, so that we have a better picture into what's actually going on. But a nice trend there month over month. And okay, so we're going to shift back to Provident. This is our throughput again. Our second group is launching. This, I think, on Tuesday we're going to be meeting with them. So again, just to set the baseline, they are in low single digits already. So 4 or 5% if you just kind of eyeball the average. So a good starting point. But we'll see if we can't get it down to consistently into 3-4 range. And similarly, throughput ED length of stay for ED discharges, they're kind of bouncing around the goal in the stretch. But again, we'll be engaging our teams to look at those process changes. And then lastly, we have our HEDIS work group. So just a call out, I know we were below goal on the trend line. We've actually switched from BI into Cerner registries, which gives us a better longitudinal picture of the patient's utilization and a better picture as to when patients are compliant. So you see there that we're above the stretch now with shifting how we're tracking the data. Conversation is looming about moving the goalpost a little bit, trying to increase the challenge here so we can continue the improvements here. This puts us very nicely. I know there were questions previously about national averages. They range anywhere from 40 to 70% depending on the payer. So we're very solidly in that mix right now and going to continue to work on improving. And then lastly, we have our blood pressure control. Again, kind of a march towards goal, which is what we've been seeing. We didn't see this bump in the switch to Cerner registries here because the measure kind of functions more as an episodic measurement. Is the blood pressure controlled when the patient comes in for their visit? So we don't really get that lift of, do we have 2 years of data coming in all at once? But still a lot of process work happening in the clinics to identify patients who are out of compliance, let them kind of stay a little longer, check the blood pressure, really try to make sure that we give them the best chance to actually meet the measure. I think that is it for the dashboard. We're going to go right into the strategy updates if there's no other questions on the dashboard. Okay, so I think the finance team did this, so this should be, yeah, okay, so not super new. But these are some of the strategies that are on the system strategic plan specific to patient safety, clinical excellence, and quality. And we'll just kind of give a quick tactic update. So implementing values in action, we have completed essentially specific behaviors that are going to drive towards the CCH values and have developed a toolkit. We've had some discussions with executive leadership about resourcing the toolkit. And we've taken that back now to the team that's working on this to really kind of hone in on specific tools, kind of really streamline it. And we're going to be going back to executive leadership to start operationalizing this. Under care management, we have a county care update here on health risk screening, 62.7% rate within 60 days of enrollment in the plan. And we are internally looking to expand the case management team as well. Dr. Patosha, I'm sure will speak to that when he comes to give his deep dive on ClinDoc. So I'll just leave that there for him. And then increasing Provident patient satisfaction, we covered that in the dashboard. We have launched the operational excellence work group there. Specific to that work stream, and we have a swim lane there specific to improving response rates on that A3. NDNQI for Provident and ambulatory, there's an expansion contract in place as of late August. They're pending purchase order approval for a system to enter the data, and then we are partnering, quality and nursing are partnering to really start launching unit councils and shared governance structures, which is going to help kind of drive performance and all of that as well. Next slide. Thanks, Debbie. Okay, maternal child health outcomes. A couple things. So county care has done a lot of work here. 2,500 car seats, 680 sleep kits, and 130,000 diaper coupons distributed between January and July. And then internal to the hospital, our OB team is working on postpartum hemorrhage as well as hypertension treatment. They have protocols and review processes in place for that. And there's a plan now next week to launch our maternal sepsis alerts and protocols. So it's not just for general inpatients. There's conversations going on with OB and as side comments as well with NICU and PICU, where we're looking at sepsis work as well. So the next tactic, county care behavioral health access.
What do you mean, just a little bit specifics about the maternal sepsis alert. What's that process look like for laymen?
Oh, of course, yeah. So much like with a general medical inpatient, right, there's signs and symptoms of sepsis. So this Cerner is going to be launching. It's a little bit different with maternal, with pregnant patients. So they have a different alert and kind of a process, right, to identify those patients. So that hadn't been launched yet in terms of the sepsis alert process. That's going to be going live next week. So it's going to help kind of flag and warn, just from an awareness standpoint for our clinicians to say this patient might be septic within Cerner. So when they log into the chart, an alert pops and says, did you consider that, right? So that's going to be going live next week.
Once again, the added value of technology.
Right. Absolutely.
Okay.
Yeah. For behavioral health improvements, County Care is working to attain 75th percentile in follow-up for hospitalization and ED for behavioral health needs. We did hire, I didn't update this one as much as I should have, but we've hired a chief behavioral health officer, so that should be in the green section. Dr. Nutter, I think he was introduced last month. However, he has quite the road ahead of him in terms of developing behavioral health services for the county, as well as, you know, assisting with development internally to CCH. So that part would still remain in yellow, but he has started down that road. So, and then maintain and improve HCAHPS measures. County Care has seen a year-over-year increase for rate the health plan. And as mentioned during the dashboard, we do have our OpEx patient experience work groups launched and working on their tactics. Next slide.
Yeah, I want to go back to the Behavioral Health Improvement Initiative. So we're doing a behavioral health assessment, obviously, at some point.
Meaning for patients coming to the hospital?
If a patient comes to the hospital.
Oh, yes.
Otherwise, we wouldn't be able to follow up.
Absolutely. Yes.
Okay, and that's a form and.
There are screening tools that they use.
Tools.
Yeah, so in ambulatory, they'll use the PHQ questions and or CSSRS. And in the hospital right now, we're using CSSRS. We actually are working with our clinical teams to kind of beef up the response to that. There's kind of a middle road of moderate risk. So we've been having a lot of discussions with Dr. Miller, Dr. Nutter, as well as, you know, our nursing teams as just to better kind of understand that middle road where it's kind of moderate risk. How are we responding in terms of monitoring the patient and ensuring their safety?
So are we below the 75th percentile now, or do we know?
Oh, so that's with County Care, and that, yeah. So I believe we are. I don't have the number for you though. I can certainly get it. Yeah. Okay, I think we covered HCAHPS. We can go to the next. There we go. Okay. So continued improvement, quality metrics, initiate leapfrog for Providence. So just kind of broader quality projects. We have service line dashboards that are launched. Press Ganey iRounds is in active use now to help improve identifying issues in service recovery. And then our sepsis rapid improvement event we've kind of talked about, so I won't continue to repeat that. And then we're looking at a crisis stabilization unit at Providence, looking at the regulatory requirements. And then, of course, I think the committee's aware that Stroger received 3 stars as well as a B for CMS and Leapfrog, respectively. And then, as mentioned during the dashboard, we do have our work groups launched for Providence, Leapfrog, and CMS star ratings, start positioning them for continuous improvements. And then the next tactic or the next strategy is left without being seen, surgical site infections and sepsis. You know, work going on for all of those, and I thought I would just kind of share where we're at. Left without being seen, as we saw, is roughly 3% for Stroger. Sepsis, this was not updated for the 93%, but it's rolling 12 months as of this month was at 51.8, which is exceeding our initial goal of 35%. And then our colon SSI is 0.6, hysterectomy is 0. And that's essentially a ratio of observed to expected infections as compared to other facilities. So if we're less than 1, that means we're better than expected. And then hospital-acquired condition compliance programs. We have dashboards deployed on our med-surg units for information sharing. And we're currently, so that's kind of the FYI, so it raises awareness for our clinical teams as to what's been happening. We're currently working with the teams to develop MDI boards, managing for daily improvement, more of an FYA for your action, to kind of track and trend the bundle compliance on a daily basis. Next slide. Culture of safety developed across the organization. So there's a gun safety module in the EMR that's been activated for screening and identifying high-risk patient situations. And then we've launched a patient safety meeting. It's been going on now for a few months. It's essentially our RCA review process. We meet every Wednesday, and we have kind of a rolling cadence of re-reviews for RCAs where we bring our tactics back to get updates and then help, identify and address any barriers that the teams might be experiencing. And then more broadly, we've engaged with nursing and a few of our residency programs around high reliability teaching, concepts around psychological safety and just culture, transparency, and so on. Maintaining oversight of clinical programs to ensure compliance with regulatory. So we have Commission on Cancer and Stroke Center designations. Both were reaccredited in the last year, and we are going to be working through a sleep reaccreditation tomorrow, actually. So fingers crossed for that. And then implementing quality dashboards. That's been completed. Our nursing team is currently tracking hospital-acquired infections, medication safety processes, so barcode scanning, and then patient experience, safety events, efficiency and throughput, and then nursing turnover. And 100 ideas. We have 120 submitted, and we have our first few ideas that are underway. They're being implemented right now, and we're going to have a big celebration after we have the first one implemented. So, next slide. This is top quality outcomes for county care members. So Health Choice Illinois reported 5 stars for women's health and doctor communication, 4 stars in keeping kids healthy. And then the Health Choice Illinois report card for county care, they're working to improve access to care, living with illness and behavioral health categories. So those 3 are a work in progress. And then Secure Center of Excellence designation. So CIRMAC received a reaccreditation. I believe they've already presented to this committee. And then we have Gold Plus for AHA for management of heart failure, and then U.S. News and World Report recognized Stroger as high performing for heart failure, COPD, heart attack, kidney failure, and pneumonia. And then redesign HRO committee structure. So we have the A3 cascading structure we talked about last month, and then we have our work groups really kind of drilling in on 2 or 3 high impact tactics each. And I think we have one more tactic on the last slide. There it is. So create more pathways for justice involved individuals. There's an auto assignment process now to county care for any justice involved patients who come through CIRMAC to get them enrolled into county care. I think that's it.
And the great thing is that everything's in progress and many things have been completed.
Yes, yeah. There's more coming behind it, but yeah, some really great stuff happening.
Thank you for the report, Dr. Mukaitis. Good initiatives moving forward and certainly opportunities to continue to enhance. Are there any questions for Dr. Mukaitis from the directors? Okay.
Thank you for the report. Thank you.
Thank you, Director Story. We will now move to our regulatory and accreditation updates with Cynthia Fish, Director of Quality and Regulatory. Thank you.
Thank you. Good morning.
Good morning.
Morning.
All right, so I'm here to present the regulatory update for September 2023. So for Provident Hospital, we are still expecting the CAP, which is our laboratory survey. It is to occur in 2023, but they have not come yet. So we are awaiting them. We did perform a second mock survey at Provident Hospital that occurred in early August. And following that, we are meeting at daily meetings that are occurring weekly, reviewing the compliance and all the corrective action items. At Stroger Hospital, we have a mock survey planned. We did write for fall or early winter in 2023. And we are also meeting with chapter owners to review the findings from the last triennial survey. And then finally, for the system, we are still ongoing our journey for health equity certification with Joint Commission.
Can you just please remind me the window for Provident and Stroger?
So Stroger will be next year in 2024, but Provident is actually coming about very soon. We don't have an actual time, but we do believe it's going to be early October.
Thank you.
Thank you. Any other questions?
All right. Any? Yep. Nope. Hearing no other questions. Thank you so much,
Thank you.
Thank you.
Cynthia. We'll now have an update from the HRR work group on clinical documentation. So Dr. Ayodeji Sohu. Thank you.
Hi, good morning, everyone. My name is Dr. Botosho. I'm the physician advisor for Cook County Health and also the co-executive sponsor for clinical documentation improvement. And I'll be talking about the HRO group, what we have done so far. So with support of the quality department, we were able to identify goals for this year, and they'll be divided into 4 different categories. On the slide, you can see they were divided into increasing our CMI, both for the surgical and medical specialty, by 10%, also improving emergency room documentation, and also to decrease our mortality index. We have several tactics that have been identified by the quality group to make sure we actually achieve these identified goals. 10% seems to be a very, very high goal to achieve, but again, we are not aware of what our nearby hospitals and competitors are doing. So we decided to go on 10% because CMI depends on the complexity of cases for the hospitals and what we are seeing here. So in regards to what we're doing, we have divided surgical specialty. We have several subcommittees, and we have leaders. So we started working with them, and that's why most of them are yellow. We've met with division chiefs and department chairs to identify areas of improvement, also with the medical specialty. The emergency room documentation, we're about getting started. We've had initial talks with Dr. Nidumab. The goal there is to improve our critical care documentation, and that should be started anytime soon. With regards to the mortality index, there are steps to actually set up a mortality committee that will be doing monthly review of cases, and I think that's ongoing, and that should be starting very soon. Next slide. So in terms of what has been done so far with some of the departments, there have been various education sessions done with critical care. Critical care, we know that's where most of our sick patients are, and actually with regards to critical care, the CMI can actually go up if you accurately document what's in there. Also, education has been done for the surgery interns, hospital medicine floor staff, and internal medicine interns. Next slide. This is the CMI for this quarter. We have 43. We have a slight increase there for quarter 3. We have 3.19. Our stretch goal, like I said, is 3.685. That's actually very high, but in terms of target goal, we're still looking at 3.35. That's for the surgical CMI. And for the medical CMI, we're looking at 1.26 with a target of 1.38 and a stretch goal of 1.518. Next one. We brought up surgical CMI to look at our surgical specialty. So if you go back to the previous slide, if you could go back to the previous slide, I just want to show something on the previous slide. So the average CMI is a product of the medical and surgical CMI. And if you look at the surgical CMI, it's like almost 3 or over 3, and the medical CMI is like 1.26. So where we are focusing on surgical CMI is that a lot of opportunity lies there, because if we actually increase that 3 to like 3.3 or 3.5, it actually, if you look at the average, it actually, and looking at the medical one, that will make a significant impact on our CMI. So that's why a lot of focus is on the surgical CMI. Next one. So regards to the surgical CMI, we have identified some specialties that we're working on, and we're looking at the CMI. There have been significant improvements in some of them, but one of them that I actually want to point out is the orthopedics department. We know, orthopedics is an area of improvement and which we're actually working on. One of the things that was done with the medical staff and hospital floors as at last month, or starting from July, the medical service actually are helping to admit the orthopedic patients. And with that, that will help us to capture our MCC and our CCs. What do I mean with that? They help us capture like hypertension, obesity, malnutrition, and make sure accurate documentation are in the notes. And we can make sure our orthopedic surgeons are in the OR. So with that, we are hoping that will help us to improve the CMI. Also, we should look at the complexity of surgery actually determines the CMI. That's why you can see cardiothoracic surgery as high as 4.8. So a lot of focus is on actually, helping our surgical colleagues to understand how their clinical documentation affects CMI. Next slide. This is the capture rate for surgical and medical capture rates. So with regards to our capture rate is still a bit on the low side compared to where we want to be. And a lot of factors actually affect the capture rate. It starts from clinical documentation and also having clinical documentation specialists, and also how our coding department. So we've been actually working closely with our coding department to make sure they're actually coding what is necessary and coding the right thing, looking at the quality of our coding of diagnosis. So more to come on the side. Next slide.
So, excuse me, can you just go back and just talk a little bit more about the capture rate and the efforts involved in what you're trying to do there, and what is the out?
Okay, yeah, we could go as much as 80 to 90%, depending on well, that's why I put on all our efforts there. So, actually, the next slide to address is all the questions. So what we're trying to do now is that the capture rate is not just about the clinical documentation alone. The capture rate, in terms of what do the doctors write, who is helping the doctors to actually make sure they're writing the right things. And also, if they are writing the right things, our coders, are they actually picking the right things from the diagnosis that have been made? Are there opportunities there? We've seen various opportunities whereby, some of these notes, we need clinical documentation specialists that will help us to tell the doctors you could have written it in a better way and to actually improve the CMI. Also, we've seen opportunities whereby actually the things are actually there, but our coders are not accurately capturing it. And those are the things that we're actually addressing now. And actually, in the next slide, I'm going to be talking about how are we trying to do that, what are we trying to do, and how do we hope to get there.
Is there a CDI team that helps the doctors?
So, yeah. So, go to the next slide.
Okay, I'll stop.
Yeah.
I'll listen.
Okay, yeah. So, one of the things we're trying to do now is we're trying to restructure our CDI. Currently, we have a contracted firm called ATOS that help us to with CDI. Yeah, ATOS has done, they've done a lot for us, but definitely there's room for improvement. So, in terms of restructuring our CDI, we have the senior leadership has been very helpful. Mr. Rochas actually approved some funds. I was still with Dr. Fagan yesterday talking about the opportunities there. One of the struggles we have is that currently our CDI is outsourced. I mean, like I said, they're helping us with, query diagnosis and things like that. But we are hoping to develop our in-house CDI program. And developing our CDI program in-house will help us, because what the physicians need is someone they can identify, someone they can relate to, that can help them with actually improving the documentation.
Yeah, documentation is a contact sport. In that, as healthcare providers get better and better at documentation, the way in which we're reimbursed is based on the documentation. And having a CDI specialists who are off-site and is problematic because it doesn't provide real time. So, doctor, orthopedic surgeon who's taking care of a patient who has a broken arm, who fails to mention that that patient with the broken arm also has diabetes, uncontrolled diabetes and hypertension, and has renal insufficiency, does not optimize the amount of reimbursement. So, what we struggle with is that we take care of very complicated patients, and our documentation doesn't reflect that. And previously, because county was the last institution in the United States that continued to be reimbursed on an encounter rate instead of based on our documentation, our physicians received no encouragement to put that those extra things in the medical record. And so now, I say it's a contact sport because everyone, it's not just county, it's Northwestern, it's University of Chicago, it's Loyola, they're all trying to recruit CDI specialists. And so we are swimming with a large pool of folks who are trying to recruit a large number of CDIs to work on site at the same time. And the competition is fierce.
Yeah, if I could add, we're going to do a review on mortality enclosed, and there's actually an example of how this applies to sepsis in there and our comparative CMI and what that does with our mortality. So it goes beyond getting payment. It's actually, it also applies to how we appear outwardly in publicly reported measures. And so it's extremely important to get it right. And what Dr. Patosha was saying earlier, I want to kind of reemphasize in that, we've been trying to educate the doctors and really trying to get them to understand, right, these comorbid conditions really are going to drive the risk scoring. However, beyond, we're now starting to really look at, we're continuing to educate the physicians, but beyond that, we're starting to look at what happens after the note is signed until the bill leaves the door. So there are multiple steps there that we're really looking to try to understand better what happens from Cerner to going to the coding, you know, the query system, back into Cerner, out to the data scrubber that's going to then send the bill out the door. There are a few opportunities that we've seen there that Dr. Patosho mentioned, and you know, there's suggested diagnoses that sometimes don't make it into the chart that maybe have the documented, you know, the required documentation.
Yeah, the coder cannot add to the documentation, but the coder may look in the chart and may call a physician. That does not happen in this organization. May call a physician and say, doctor, while the patient was here, did you happen to treat the patient for their hypertension? While the patient was here, was there any attention paid to their elevated cholesterol? These are things that they may have seen in the chart or seen in previous charts that may not be added into the documentation. So there's a lot there.
So as a specific example, obesity, something that we've been kind of looking at that is a big driver of risk, we code in about 5% of our charts where our comparative hospitals are catching 30 to 40% of the time. So there's a huge opportunity there to start finding those comorbid conditions. It's not that the doctors, in that case, we've kind of drilled into, and it's not that the doctors aren't documenting it. There's a BMI in those charts. It's suggested, it's just not getting into the codes, right? So it's not getting added in kind of the back of house process. So a couple different places for opportunity.
Yeah.
And this will be even more so going forward when people, as we continue to talk about value-based reimbursement.
So shifting value-based reimbursement, this becomes incredibly important in the ambulatory setting as well. They have, with our Medicare Advantage plans, there's something called the RAF score, which actually drives kind of the targeted spend for that patient population. So if you're not getting the credit and you're giving the good care, you're still, your targeted spend, you're not going to be able to get under that target spend to actually generate a shared savings pool. So as we go into the value-based care, it becomes incredibly important across the continuum.
I didn't mean to jump ahead of you, asking questions about CDI, but I see I now see the next slide. I see all the questions. My questions have been answered.
Yeah. So yeah, we are hoping to, so one of the things we're doing now is that we're, through the support of Mr. Rocha and Dr. Vega, we are hoping to get CDI physician department leads that we've identified 12 clinicians in like different divisions and departments that are willing to actually do the education and possible certification that will be leading various departments and will be serving as their leads there for their clinical documentation improvement. Also, recently, we have 4 CDI specialists that have been approved for us that will be posting and, you know, that will be hiring. Also, we've had, like Dr. Fagan said, we've had almost 2 years challenge now because of the market hiring a CDI manager. But there are talks now in possible having a CDI physician advisor that could help us see that area. So in the next 2 weeks, I think we are talking to a firm that actually have been able to help in building a CDI program. And they are coming to talk to us to do a need assessment and to see where gaps are and how we can improve our CDI program.
Other questions from directors? Thank you.
Great. Thank you. Yeah.
Thank you. Good progress. I think the other thing that may be being talked about or thought about is, you know, how do we use AI and other tools to support clinical documentation? All right, we'll move to action items. Section 4. To approve reappointments of Sturger Hospital Department Division Chair. So Dr. Fagan. There he is.
Yes,
we have,
so,
yes.
Right. The goal that we have is actually to get to a point that we are reappointing our physician leaders, department and division chairs at the same time that they're up for reappointment for their credentials. So we have been working through this process. There's been a bit of a lapse, and so we're trying to catch up so that we can do this all at the same time. So you received a list of 19 leaders in department and division chair positions. I'll be happy to answer any questions about them, but since you received it in advance, I won't trouble you with reading through the entire list. But these are all folks who have been in these leadership roles, and we're continuing them as their credentials are continued.
Thank you. Directors, do you have any questions on the documents presented?
None on my part.
All right. Well, I'd like to entertain a motion to approve item 4A, the proposed 5 Stroger Hospital Department Chair reappointments and 14 Division Chair reappointments. Do we have a motion?
So moved.
Seconded?
Second.
All right. Motion has been made and seconded. Is there any other further discussion on this motion? Hearing none, then all in favor, say aye.
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 All opposed? All right, the motion carries. Thank you, Dr. Fagan and directors. Now we'll move to the MSMEC reports. Dr. Akintoran, President of the Stroger Hospital Executive Medical Staff. Thank you.
Thank you. Good morning, Chair Bat and Directors.
Good morning, Doctor.
Yes.
Morning.
So you have before you the report of the medical staff appointments and reappointments and other changes from our credentials committee passing through the medical staff to you today. And there's nothing, extraordinary to report about that. The work is complete and regular. And if you have any questions on those, I'll be happy to entertain them. And I will go to the summary report of the HQPS committee from the meeting of July 2023. I will give some information that will complement what is projected up there. The first is environment of care. That was focused on food and drinks in the clinical workplace. We don't want our trainees and our other employees to keep food and drinks in the workplace where the place where we store equipment and pharmaceuticals, and they could be contaminated from the hazardous materials and chemicals used for cleaning and for treating of patients. So there is a focus on that. Also on removal of power strips and microwaves from private offices for our staff to get rid of those wherever they are existing at the present time. Also, red bag waste to ensure that we are using those appropriately, because waste that do not belong in the red bag waste, it actually harms the environment. The processing and all that, and it's not a good thing. People should not think, oh, red bag waste is good, it's better for everything. So it's not. There was also a presentation by Dr. from the laboratory about fecal occult blood and immunotesting. They have some new processes there to eliminate manual work, such as plaque input, and this has resulted in faster turnaround time, a lot more samples being screened and processed, and improved efficiency. For radiology, CT scans and ultrasound tests for safety discharges had a 100% completion rate in the second quarter. Unfortunately, we are not meeting our goals for CT scan turnaround time, MRI for stroke protocols, ultrasound for inpatient volume and possible X-rays. There's a lot of focus on all of the above, but we are still far from meeting our goals. In the area of patient relations, there were a total of 641 complaints in that quarter, which is actually an increase. And the majority of those were coming from the issues of safety, quality of care, lost items by patients, and many of those are from the emergency room. There's a strong focus on care in order to improve patient experience. HRO documentation, HRO clinical documentation work group. We are observing that we're in a stable phase of CMI and our documentation efforts. And on what is being done about that, we do have updated information from the presentation by Dr. Gotosh and Dr. Figan on hiring CDI managers and CDI specialists and CDI physicians and all. So you had a lot more detailed information about those. Okay. So thank you. I'm sorry, I came straight from the operating room. Okay, so I'm happy to respond.
Thank you.
Reach me. Okay. Thank you.
Thank you. Any questions for Dr. Katoran?
Thank you.
Thank you for the updates. Thank you. I'd like to ask Dr. Lofman, Chair of the Department of Family and Community Medicine, to present to the Provident Hospital Quality Committee for informational purposes. Thank you. Good morning.
Good morning.
Reporting out from the July highlights. Of course, a more detailed list of the minutes goes to the Med Executive Committee for review, and this is just a summary of the highlights. So, medication fill accuracy for all practical purposes, 100%, April 22 through June 23, which was something we're proud of. Barcode administration continues to improve. There's some gaps identified in the ED with quick registration and other places where there is occasionally a lapse, and they're still working through that. In terms of patient access, monthly registration in the ER also continues to improve. A very similar factor there related to the quick registration and trying to get meds quickly to patients before they're formally registered. So those two things are somewhat related. And then on ancillary services, they're approaching 100% accuracy on registration there, which is what we're looking for. We always like to highlight the work of behavioral health. We have so many of our behavioral health patients that are not engaged in primary care. They come fortunately for their psych care. So there is a national initiative, as you know, to focus on that. So lipid levels are being drawn almost 100%, 97% of the time for patients to come through. And then it says hemoglobin, it really should be hemoglobin A1C, screening for diabetes, patients with diabetes to be screened. And this does allow, they're actually exceeding goal on there, and it does allow behavioral health staff to triage the patients who do need to get back into primary care because their conditions are uncontrolled. Identify those and then get them engaged. So they tend to refer the patients over to us. Then they're not, of course, managing the chronic disease, but they are identifying their patients who have those comorbidities. And lastly, for behavioral health, the Columbia suicide, self-harm, risk of self-harm screening is at 100%, which is what it should be, what we expect it to be, and that's been the result of a lot of great work by the behavioral health team to be able to get those goals there. So that's a summary of the highlights. There's no particular action items for either the NBC or QPS coming to you today. Thank you.
Thank you.
Thank you. Any questions? All right. Thank you, Dr. I'd like to entertain to see if there are any other sorry, I'd like to entertain a motion to approve item 4B. Which, we did do this around medical staff appointments and reappointments and changes. Any motion to approve?
So moved.
Seconded.
Second.
Any discussion? Nope. All in favor, say aye.
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 All right, motion carries. Now we'll go to the minutes from August 17th, 2023. These were approved by the board at the August meeting, but being presented for the committee's review and discussion necessary. Any corrections or need to be made to the minutes? All right, I'd like to entertain a motion to accept the minutes of the QPS committee meeting of August 17th.
So moved.
Motion has been made. Any seconds?
Second.
Okay, thank you. Any discussion? No. All in favor, say aye.
Aye.
All right, motion carry, or all opposed say no. Motion carries. Thank you. All right, we'll next move to our next item with Dr. Loafman and David Brady on proposed Provident Hospital 2023 quality patient safety plan. All right, thank you, Dr. Loafman and David.
Yes, thank you. David and I will present, we have about 24 slides. We're going to go quickly. A lot of it will not be new to you and your role in the quality board, so we'll jump right ahead to get through this. So why have a quality patient safety plan? As you're well aware, the purpose is to have systematic organization and trying to help move us toward quality improvement and away from quality assurance looking at the past. And of course, QPS has a plan designed to do that, which is outlined here, and we're going to get into that a little bit further. It aligns well with the Joint Commission expectations and our own QPS plans from a health system point of view. And again, the future goal is by next year that there'll be one system-wide plan and not separate campus plans going forward. So next slide. What's new? So this is a little bit of the change already for the last few years, and content has been decreased to focus more on some of the highlights, adding a table of contents, adding some appendices, adding references where the data comes from and showing that it is current and up to date, and then including that in annual program evaluations updated. So this is all through great work of the quality department to help bring us up to speed. Next. This is just a quick look at the table of contents to show it's a shorter narrative content. It's much more focused and has a robust table of contents. Next slide. The mission, vision, purpose, again, not new to you at all. This is your role in the quality committee too, but deliver integrated care and services as a public health system, and a vision really to fulfill our public mission for both patient-centered care, fiscal responsibility, equity, et cetera. Next. What exactly is quality? Again, don't mean to lecture you about this. This is your role, but this is really to focus on the effort to continue to move ahead, focus on continued improvement and quality improvement, and not just to rely. Of course, there's lots of quality assurance look back responsibilities that we will do and always do, but this is really to try to help the committee and all of our team move forward, looking ahead to do it right the first time rather than focus on what went wrong last time. Next, I'll turn it over to David, who'll pick it up from here with our goals.
Good morning. Good morning, Chair, Good morning, directors. So the goals that we established is to promote a culture of safety throughout the organization. Then we also obviously want to improve safety reporting events to ensure a safe environment for reporting events, and then also so things are addressed in a non-punitive manner. We want to document our events in EMERS, which is the system that we use, expand our evidence-based practices, obviously work to reduce any serious safety events, conduct proactive risk assessments, and then also monitor and improve patient experience surveys. Next slide. This is an overview of the organizational structure for quality. As you can see, hospital quality and ambulatory are two separate ones for each of the hospitals, and then of course we report up here to the board for QPS. There may be additional changes, but right now this is the current structure as we stand. Next slide. So obviously this is the board of directors' responsibilities. I'm not going to read your responsibilities to you, but this is obviously the list of them, and obviously the chair, Mr. Chair Taylor, and then also the list of the directors on down the list. Next slide. And again, also QPS board responsibilities. Certainly not going to tell you what the responsibilities are, but you can see the list as it goes through here, and we list out all the individual members and what the activities are and the purpose of why we have the individual QPS committee. And I'll turn it back over to Dr. Wilson.
Thank you. Yeah, so the Med-Exec committee responsibilities is an area of focus for us to be sure we're not just bringing things forward ad hoc, but we're bringing the QPS committee's work done on a regular monthly basis to Med-Exec committee. But the full scope and responsibilities are outlined in the bylaws and policies and procedures. But we make recommendations to you, of course, and through you to the board on credentialing and privileging, which we do each month. We provide leadership for measuring and assessing quality and improvement processes, overall performance improvement activities, and then reviewing the med staff compliance with standards and regulations set forward. So again, this is an area I think that we've done fairly well, but we're trying to tighten up and make sure that it's done more formally going forward. Next. And the QPI committee, and et cetera, this is sort of a busy slide with all the different groups that are breakdown there, but I think, again, we bring highlights forward to you, a little more detail to MEC with all these responsibilities. But the scope really covers the comprehensive work of care that happens on the Provident campus. Next. This really looks at the methodology and framework for the PDSA or PDCA cycle that we review. We reviewed this a few times with the committee members, and so part of it's just really helping them not just do a one and done project, but to work this continuous improvement concept. Next, we have a few slides that look at the examples of this, and this is the ER turnaround time, for example, for a CT scan. So this is an area where we wanted to make improvements. It's something that not one department can do, but it requires transportation, ER staff and radiology staff to work together on that. So it's a good example of a PDSA process that works across disciplines. Next slide shows another example of on-time starts. So we bring a few of these forward because you can see the curve is there's an improvement, but it kind of flattens out over time. And so one of the things that we do with leadership on the committee is push back a little bit with our various work groups and say, you know, the PDSA process should continue. You know, this is kind of flattened out here. How do we tweak and improve to continue to make things go forward and not distract us? And the next one is very similar on operating room turnaround times, where you see some improvement, you see it flatten out, and then there's a repeat initiative to use PDSA to tighten up and show improvement there toward the end. That's what we're looking for. I'll turn it back over to David to talk a little bit about alignment with Joint Commission.
Okay, so as we know, the alignment with Joint Commission, the three standards that are most relevant, obviously, for PI is data collection, data analysis, and performance improvement. And really what it should say is continuous data collection, continuous data analysis, continuous performance improvement, because that's essentially what we're trying to accomplish. And so this is just an overview of the chapter of all the PI requirements that we have to go through. Next slide. So next slide. So patient safety program, one of the things we have in place, obviously, is the CERT team, the Serious Event Review Team, which then gets cases are analyzed and forwarded to the appropriate committee or closed, wherever the case may be, also forwarded to the Hospital Oversight Committee. And the idea is that we focus on improving systems and processes, and the emphasis is going to be placed on corrective action and individual development to assist staff, but not necessarily punish them. We want to try and develop a psychological safety mentality as we go through. Next slide. Again, continuation. The other part of patient safety is the failure mode effects analysis that's required. We have to do one annually. I believe this one that was done this year was on the elopement, and so that's one of the requirements that needs to be included in our reports. And then additionally, staff and receive education and training through their orientation about job-related aspects. They are counseled, they're talked to about how to report safety events and where to go to if they have issues to resolve. Next slide. This is a simple classification of how we classify serious safety events. Obviously, the lower ones in the bottom are less severe. Those are near misses. They never met the patient. The middle ones are the ones that have actually met the patient. There could be harm or no detectable harm. And at the top of the pyramid, obviously, those are serious safety events. We want to keep everything as low as possible. Ideally, we don't want near misses, but we also feel that near misses are helping us to find the issues that are going to help us find the issues so that we don't have precursors in serious safety events. Next slide. Root cause analysis is the process that we use for serious safety events. Those are typically ran through our patient safety area and also Dr. McKitis. The RCA is a standardized tool that we have to use, and it's been, established by the National Patient Safety Foundation. And these are all, again, reported and collected and reported up to the appropriate committee. Next slide. Again, failure mode effects analysis. This is the one requirement that I mentioned earlier that was done on elopement. That is an annual requirement for the quality and patient safety plan, at least once a year. One of these has to be done, a topic that would be appropriate for failure mode. Like the one was elopement that was done, there'd be a significant impact if that failed. Next slide. And everybody's favorite, this is the annual program evaluation that I send out every year, and I ask people to please update their metrics. Tell me if those metrics are still good, if they need to create new ones. And so every year we go through this process evaluating the metrics that we're worked on. Did they improve enough to be let go? Do we need to add new metrics? Do we need to change it? And so this is also going to probably end up changing down the road as well. We're in the process right now of developing a new way of looking at metrics, but right now this is the program evaluation that we have in place for all the individuals who participate in the quality program. And that includes both Stroger and Providence. Next slide.
So this is part of the future state relative to consolidating the quality plan going forward?
As of now, this evaluation will still be included. We may modify it down the road, but right now it's still included.
So there's a plan in place now to create a system quality plan. This is being done right now to meet a regulatory requirement for, this has to be approved through the board for the TJC survey. So that's when Providence going out. We're not quite ready to present the full system plan.
Thank you. Next slide.
That completes our report.
Any questions?
All right.
Good,
Thank you, Dr. Lofa.
Shouldn't have any
Thank
problems with
you.
the Joint Commission.
Yes. We have to entertain a motion to approve the item 4E, the proposed Providence Hospital 2023 Quality Patient Safety Plan.
So
We have a
moved.
motion. Second.
Second.
Any further discussion on the motion? Hearing none, then all in favor say aye.
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 All opposed?
When did the S change to C, from C to S?
Motion.
I guess I was just,
Lead S.
shouldn't be saying that out loud, I'm telling my age.
All right, well, thank you. Motion carries, appreciate it.
Thank you.
Thank you. Now, we'll make a motion to go into closed session.
So moved.
Seconded.
Seconded. All right. Any discussion on the motion? Hearing none, all in favor say aye.
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 Chair, we do need a roll call vote, and we need to cite the exceptions to the Open Meetings Act when we make the motion.
There you go. Pursuant to the following, entertain a motion to go into closed meeting pursuant to the following exceptions to the Open Meetings Act. ILCS 122, so 1, 11, 12, and 17. So, Madam Secretary, can we please take the roll call vote on the motion?
Roll call vote on the motion to go into closed session. Aye or nay, Director Garza?
Aye.
Director Harrington?
Aye.
Director Sorrell?
Aye.
Director Story?
Aye.
Director Webster Cross?
Aye.
And Chair Bott? Did you say aye?
Aye.
Chair Bott? Thank
Aye.
you. That's 6 yeas and 0 nays.
All right. The motion carries. The ayes have it. We'll now go into closed meeting. If the members of the public and those staff are not required to be in attendance, then please exit the room. We can get started.
Okay, so if everybody remotely